Good evening and welcome everyone to the latest installment in the UVA Department of Radiology and Medical Imaging Keynote Lecture Series. We have an excellent evening tonight. We are looking at an ongoing, challenging, and interesting area of cross-sectional imaging and interventional radiology, which is how can we best evaluate therapeutic responses to trans-arterial therapies, particularly trans-arterial radioembolization of hepatic tumors, so very important in treating so many primary and metastatic malignancies in the liver. And we have spectacular speakers tonight. I'm going to do the brief introductions now. We have as our invited speaker from the outside, Professor Frank Miller, renowned for speaking on this topic. He's the Chief of Body Imaging and Fellowship Director of Body MR at the Northwestern University Hospital, Northwestern Memorial, and he's the Lee Rogers Endowed Professor of Medical Education at the Northwestern Feinberg School of Medicine. That's the very short of a very long list of accolades. If you're not aware, Northwestern has and remains as the pioneers in transarterial radioembolization and thus imaging as well. I'm very excited to have Frank and equally experts from University of Virginia, Professor Rachita, Khot, who is an associate professor and director of ultrasound in the department as well, and also Professor A.J. Pesch, who's an assistant professor of abdominal imaging, who brought their own materials for discussion with Professor Miller. And with that, I welcome you all. Grateful. Stage is yours, Frank.
Can you see my screen, or let me share it? Hold on. Okay, so I'm going to be discussing state-of-the-art cross-sectional imaging after trans-arterial therapies, especially radioembolization of hepatic malignancies.
Do we all see Frank's screen yet? Apologies. And perfect.
Okay, sorry. I don't have any disclosures related to this talk. I'm a consultant for Bayer Healthcare and Guber, but it's not related to this presentation. So my objectives during this talk are going to be to discuss the unique aspects of interpretation of radioembolization, some of the limitations of our traditional size criteria. I'm going to emphasize the importance of necrosis. I'm going to discuss thin rim and nodular enhancement, diffusion-weighted imaging, and I'm going to discuss the relatively recent techniques of radiation segmentectomy. This is an example of one of the challenges of the interpretation when we used to do low-bar therapy and lower doses of yttrium. This was about 10 years ago. So you can see this relatively large mass and several satellite lesions involving the liver from HCC. And this is 1 month after therapy. So at this point, I would probably, call Riyadh and say, did you target the lesion, let alone the liver? It's hard to even, see that there's been any response, but this is where I learned a lot from, because this is 3 months later, and this is without any further therapy at that time. Notice this is 1 year later, 16 months later without any therapy. In most places, the patient would no longer be alive, but you could see at 22 months, an outstanding response. And I went from being a nihilist to a believer just based on this particular case. As I like to say, interpretations of images after interventional therapy is among the most difficult in radiology. Certainly no one fights to read these cases. These are the cases that often stay on the PACS work list until a fellow or resident probably mistakenly opens it up or feels guilty. But I think after a lot of experience, I actually enjoy reading these cases, and I feel a lot more comfortable, obviously, than I used to be. And the reason that these are challenging is because the size may not decrease, or you may paradoxically see an increase in size following embolization. And this is felt to be due to hemorrhage and necrosis. In addition, it's important to recognize that there's really no uniform standard of interpretation, as I'll talk about. In addition, ring enhancement can be mistaken for tumor, and it's actually often a good sign of a good response after therapy, and it's felt probably due to scar tissue or reactive edema. Also, it's important to recognize that nodular enhancement after radioembolization is not always tumor, unlike RF ablation or chemoembolization, when we generally suspect that it's tumor, and we go back in and have them retreat the patient. Our traditional chemotherapeutic agents are cytotoxic and they eliminate neoplastic cells. As a result, the change in tumor size, and usually you get disappearance of the lesion. And this is the only widely accepted and validated radiologic marker of treatment response. Unfortunately, often this doesn't apply as for local therapy for HCC, as I will show you. Why do we do these types of therapy? Well, the vast majority of patients with hepatocellular carcinoma are not candidates for orthotopic transplantation due to them being outside the Milan criteria. For the Milan criteria, you want to have 1 nodule 2 to 5 centimeters or 3 nodules, all of which are less than 3 centimeters. Another reason that they're not candidates for transplantation is because they could have tumor in the portal vein, which is in general a relative contraindication for chemoembolization and certainly for RF ablation as well. And a lot of these patients may have metastatic disease. What are the different treatment options? Well, there's a lot of different treatment options for people who don't qualify for transplantation surgery and those with liver metastases. From a radiologic standpoint, you could do various types of ablation, RF ablation, microwave, cryotherapy, and alcohol, amongst others. Transarterial chemoembolization, as well as TACE, as well as yttrium radioembolization, or a form of combination of these therapies, as well as systemic therapies and now immunotherapy as well. And these are methods to bridge or downstage patients for transplantation as well. As I mentioned, it's important to have standardized reporting, and different institutions report their findings differently, which can affect transplantation and treatment assessment. Some places will look at the size of the lesion, including the necrotic part, while others will look at the enhancing part. I feel that the enhancing part is the most important, as it's more likely due to tumor, and that's what the newer guidelines, the MRECIST and LRTR criteria, are using. It's also important to recognize that evaluation is especially challenging given the radiation necrosis, with changes developing over a period of 3 to 6 months instead of being necrotic immediately following RF ablation or chemoembolization. In addition, unlike chemoembolization or RF ablation, as I mentioned before, nodular enhancement is not always tumor. And I'll show you some examples where it's clearly that if you had thought that the nodular enhancement was abnormal, you may be mistaken, because it's not always tumor, or maybe tumor that takes a longer time to respond. Also, another big challenge is that you see radiation changes in the surrounding liver, making imaging interpretation challenging. So this is an example of chemoembolization, where you have a patient with a hepatic arterial and a portal venous blood supply. This is an interesting case because we used to have this one unit where you can do MR in one room and IR in the other room, and then you can wheel the patient back through the same table, connecting the two. And this was with an intra-arterial injection. So you could nicely see the different HCCs with the classic arterial enhancement and washout. And immediately following the procedure, this is with an intra-arterial catheter still in the patient, you can see that the lesions are necrotic. So tumors, especially HCC, as you know, are almost completely supplied by the hepatic artery. And the way the chemoembolization works is that the tumors are treated, as illustrated here, by injecting the hepatic artery with embolic material, chemotherapy, as well as radioembolization is another method. And the goal of chemoembolization is to obstruct the feeding artery, causing ischemia and accumulation of the chemotherapeutic agent within the tumor. What about the type of imaging follow-up? Well, similar to the type of therapy, this often is institutional dependent, with the modality being either CT or MRI. We often use MRI for HCCs, and we often use for metastatic disease CT, because we want to often look at the lung and other areas in the body as well. And for the timing, at least at our institution at Northwestern, is following RF ablation, chemoembolization. We image them immediately after the procedure. Generally with CT, we look at the lapidol accumulating with chemoembolization, and then we image it 4 to 6 weeks, and then every 3 to 6 months. In contrast with radioembolization, we don't image immediately after the procedure, but we image typically at 1 month, although a lot of institutions do not image at 1 month, but image at 3 months, and then we image every 3 to 6 months. As I mentioned, the imaging results following TARE are seen much later than with chemoembolization and RF ablation. And there's different ways to assess therapy. You can look at a decrease in tumor size, which is the classic approach for therapy, whether it's WHO, RECIST, or volume. But I want to emphasize that necrosis becomes a lot more important to assess. And that is assessed using EASL, MRECIST, and LI-RADS treatment response criteria. And as I'll try and show you, I find diffusion-weighted imaging helpful. Other places also may do perfusion MR, and also PET scan can be helpful, especially in the setting of metastases. As I want to emphasize, again, there's no standardized reporting, and the type of treatment and the imaging study should be based on your expertise of your own institution. This is a nice slide that was lent to me by Joseph Yacoub. I'm part of the LI-RADS treatment response group, but you can see that the treated lesion, you evaluate whether it's non-evaluable because of image degradation or omission, and then you put it into 3 categories, either non-viable, viable, or equivocal. But these can be challenging, as I'll show you, to assess following radioembolization. And the way that it currently stands is radioembolization may not qualify as well because the treatment response viable category, as I mentioned, is looking at nodular mass-like enhancement, and you look for arterial phase enhancement, washout, or enhancement of the tumor prior to therapy. In contrast, obviously non-viable, you're going to see no lesion enhancement or treatment-specific expected enhancement response. And equivocal is if it's not clear one or the other. And if you're not certain, then it's referred to as equivocal. Well, there's just debate about whether equivocal is the right word to use because it almost sounds like you're equivocating as opposed to being more certain. Here's an example of chemoembolization, nicely illustrates an HCC. You can see the nice targeting of the lesion. You see the thiodol within the lesion. It's filling the lesion, so you know it's targeted well. MR can be helpful because with CT with the thiodol, it can be hard to assess, but you can see that it was bright on the pre-contrast images, probably from hemorrhage. Following contrast, you can put an ROI and see that it's not enhancing. You can also do, which we frequently do, which is an advantage of MRI, is you can do subtraction. And using subtraction, you can see it's an LRTR non-viable lesion. There's certainly no enhancement. There's enhancement of the rim, which is normal. This is a 71-year-old female with HCC, was treated with chemoembolization. Nicely can see the HCC here. Again, you can see the thiodol accumulating in the lesion. 1 month later, you can see there's good response. It's smaller. 6 months, it certainly looks like it's been a good response. It's still getting smaller. You can see by 10 months, though, there's a small nodule of enhancement, probably recurrent disease along the margin. At 25 months, even though it's a small nodule, it grows very slowly. And you can see that it's growing. So it was retreated, in this case, I think, with ablation. This was a study that was done by Riyad Salem and a number of institutions. This actually, I'm sorry, I misspoke. This is from our institution, where it's basically a paper justifying the use of radioembolization. This was informed by a 1,000-patient, 15-year experience. And as mentioned in this article, radioembolization is the main form of therapy for HCC, at least at our institution. It's, for those who don't know about it, it's a beta emitting isotope, which is loaded on microspheres. Here's a schematic of it. These are microembolic. They're lodged at the arterial level to treat the tumor with radiation. What's nice about it is an outpatient procedure. There's rare side effects given the selective injections. The patients can go home after the procedure, and it has evolved significantly since it was first used. And it's basically effective in all stages of HCC, especially the early stage with outcomes comparable to curative surgery in early HCC, but we can use it in all the different stages. And what's interesting too is that there's a number of patients that we've done who were not transplant candidates, or you were able to bridge the patients so that they didn't have advanced disease at the time of transplant. And some of these patients who didn't meet this criteria for transplant were able to get transplanted. This is the other paper that I was referring to. This is a paper that the legacy study, which allowed FDA approval, which was recent for radioembolization. And it's based on multi-institutional legacy trial of 162 patients, unresectable solitary HCCs, all less than 8 centimeters. They all responded with a mean survival of over 58 months, and 93% are survived at 3 years or were transplanted, 87% in the others. Complete necrosis was seen in the patients treated with a higher dose, those with over 400 gray, and none of the patients had radiation-induced liver disease or major adverse effects. So a lot of the effects that we used to write about as complications are not being seen with these better techniques. Here's an example. This is a patient who was treated. Post-treatment, you can see the lesion hasn't changed in size, but nicely demonstrates necrosis. So I want to emphasize the importance of necrosis. This was non-viable at the time of explant. And you can see the explant here. What's interesting is here you can see the dead tumor. You can see the narrow zone of transition, and you can see the normal liver adjacent to it on this nice schematic of the gross specimen as well as a microscopic slide. This was one of my earlier papers with radioembolization. As I mentioned, this was from 2007. I didn't want to say that everyone was a failure of therapy, so I wanted to look at the therapy and see what happened. And what was interesting is using this low-bar therapy, if you looked at the WHO or RECIST criteria, which are size-based criteria, it took 120 days to see a response, which clearly is too long. If we look at necrosis, we start to see a response by 30 days, which was a lot earlier. What was also interesting is there was no correlation between the response and the initial size, whether it was a 6 millimeter lesion or a 19 centimeter lesion, they still responded. And whether there was tumor in the portal vein or not, they also responded. And the AFP was value wasn't correlating either. Here's another example. This again was with low-bar therapy, but you can nicely see a lesion here, 3 centimeters. After therapy, it's clearly larger, but this is dead tumor at the time. This is a newer technique that I want to focus on. This is radiation segmentectomy, which is very exciting. And what it does is we look at selective delivery of higher doses, typically over 190 grays, to 1 or 2 Khot segments to maximize the radiation without adjacent liver damage. And it allows treatment of the satellite lesions in the radiated area, so it's curative and it avoids some of the recurrences that we used to see at the tumor margins and some of the other types of therapies may see. It's most impactful at places where you can treat the lesions where ablation may be challenging, certainly the hepatic dome, Khot, hilum, and locations near vessels and bile ducts. And this is a schematic from a radiographics article that was just recently published in 2022, which you can get more information about my lecture as well, if you're interested. This was 2 different studies, again, done by Dr. Salem. The first one was a radiation segmentectomy. They saw a complete response in 47% of patients with a mean time to progression of 33 months and overall survival of over 53 months. What was interesting, a third of the patients could be transplanted or resected, with explant showing nearly 90 to 100% necrosis in all the patients. And the threshold dose of 190 gray was used to achieve a complete pathologic necrosis. The second paper was interesting because it used over 400 gray, and it showed that there was 100% complete pathologic necrosis that can be achieved if you use that higher dose. Here's an example of radiation segmentectomy pre-treatment. You can see the lesion. You can see it's nicely targeted. I want to emphasize looking at the DynaCT when you're reading these studies. Post-therapy, you can see it's certainly about the same size maybe, but there's rim enhancement, but now it's necrotic. That's showing that there's been a good response. 6 months later, you can still see that enhancement. That's normal, the perilesional enhancement. Even a year later, you can see the perilesional or even what appears to be the lesion enhancing, but it's clearly a great response. You no longer have any tumor at that level. Another example, here's an example near segment 4, 1 month follow-up. Again, it looks necrotic. And 6 months later, it nicely illustrates that capsular retraction and the atrophy that's associated with the radioembolization. And it's often seen, and it still has a good outcome. So I want to specifically talk about certain features that you see after radioembolization. We're talking about thin rim of enhancement, radiation effects, nodular enhancement, capsular retraction that are all associated with radioembolization. This is that thin rim of enhancement that I talked about. You can see the lesion here. Is hypervascular. You can see that thin rim of enhancement that was seen in about a third of the lesions, and it appeared anywhere from the first month to 6 months, and it persists for months with a mean of about 4 months. It's a benign finding. It's not to be confused with tumor. It's actually granulation tissue, and it often corresponds with a good response. Here's another example. This shows how it can be challenging to interpret these studies because you start to see this perilesional effects. But what you learn is that this is an inflammatory reaction, and it shows that the lesion's been effectively targeted. So if I see this perilesional effects, I know that especially if it's along the zone of the treatment change, then I feel good about the adequate targeting. And this can persist for months, and it shouldn't be confused with tumor. It usually resolves within 3 to 6 months, but it can persist for quite a while. And it could be bright on T2, and it can also be bright on diffusion. Another example, here's pretreatment. I like to look at the angiograms or the CT angiograms when they do it to make sure that it's targeted well. But nicely, you can see at 1 month, this was completely necrotic. You can again see that perilesional effects. You can even see those perilesional effects at 6 months. You can see a rim of enhancement. I don't worry about it. If there's a rim of enhancement, this is an excellent response. And I would report this as a LRTR non-viable. What about that nodule enhancement? As I mentioned, that's not always tumor, and that's a limitation of our interpretation, our MR RECIST and our LRTR guidelines for assessment after radioembolization. It could persist for a mean of as long as 5 months, and this differs, as I mentioned before, from RF ablation or chemoembolization, where it's generally tumor. We're not sure exactly what it is, but I feel like it's probably more likely to be a slowly treated tumor or post-treatment changes or untreated tumor from a different blood supply and not a treatment failure. And you have to always assess the lesion, especially the ones in the domes, because those can sometimes have a different blood supply, at which point they may retreat the patient, but it's not a failure of therapy. And a complete pathologic necrosis at explant was seen in 38% of these patients with nodules. Here's an example, hypervascular lesion. Clearly see that there's a nodule enhancement. But what's interesting, this was not retreated. This is 6 weeks later. This is 3 years later. So you can clearly see that nodule of enhancement that you might have worried about is clearly not tumor. What about capsular retraction? As I mentioned, that's a normal finding after radioembolization. It's due to necrosis, fibrosis, and scarring. It's seen in a large percentage of patients, 89% of patients in one study after radiation segmentectomy. Here's that example I showed before where it nicely illustrates that the volume loss associated with it, but you no longer see the lesion at all. What about this patient? Well, this patient has portal vein tumor thrombus, which obviously is a bad prognostic marker. Generally can't be respond to RF ablation, obviously can't be transplanted in general. Although now with radioembolization, even patients like this can potentially be transplanted, because you can see here, this is 1 month later. You might say that there's still residual tumor, but notice how it's a lot less dense. And I think that's a very effective feature to show that there's been a response. 3 months later, this is 26 months later, one treatment, and you could see that there's been an excellent response. This was the second paper that we did. We looked at HCCs, but we thought it was also important to look at liver metastases and look at size, necrosis, and PET scan. Again, an increase in size could be seen in the responding lesions, making the size criteria more limited. Necrosis certainly helped, again, to show a response. And PET in these patients, although we don't routinely always use it, it showed an earlier response in metastatic disease, although it didn't detect some of the smaller lesions. So here's an example. You can see this is a patient with colon cancer, and you can see sometimes it's hard to assess therapy. It's not a hypervascular lesion, as we'll talk about in other cases, but you can see that it's a little bit less dense, less enhancing. It's an easy diagnosis on PET. Obviously, you can see it has activity and no longer has activity, complete response. How about this patient? Well, here too, colon cancer, several lesions, hard to see that there's a response. Maybe it's a little bit less dense. In this particular case, it certainly could see that in the setting of a PET scan, that went from having activity to no longer having activity in the vast majority of the lesions. How about this patient? Well, this patient, if you use the criteria that I mentioned before, you can see that it goes from enhancing, even though the size hasn't changed, it's certainly necrotic at this point. In this particular case, we don't use routinely PET for HCCs, but in this case, this patient had a PET avid tumor, and you can see that it no longer has activity. What about diffusion-weighted imaging, and how does diffusion-weighted imaging work? Well, when we're looking at enhancement, we're looking at the percentage enhancement on the arterial and the portal venous phase. We're looking at the extracellular space. We're looking at tumor vascularity as illustrated here. If we're looking at diffusion, we're providing functional imaging information in addition to anatomic. We're looking at the altered water mobility. We're looking at the cellularity and the integrity of the cell membrane. The advantage of diffusion, it doesn't require contrast material. What you're looking for is more free water and a higher ADC or apparent diffusion coefficient after therapy, and it can be seen prior to changes in size. So following therapy, to oversimplify it, tumors that initially have restricted diffusion or dark on ADC maps become less restricted diffusion. They become bright on the ADC maps. You see an increase in the ADC value. And some of these changes, as I'll illustrate in the ADC, may precede changes in the size of the lesion. So oversimplifying it, if you have viable tumor, it's bright on diffusion, dark on ADC. It has restricted diffusion, although not all HCCs restrict diffusion, as well, as you probably know. But successful treatment, you look for it becoming dark on diffusion-weighted imaging and increasing in their ADC values. Here's an example: arterially enhancing lesion, washing out, shows capsular enhancement, certainly is bright on diffusion-weighted imaging. Following therapy, if you use the criteria I mentioned before, it's no longer enhancing, but your confidence level sometimes is improved when you could see, similar to a PET scan, you no longer see a restricted diffusion, similar to PET where you wouldn't see any activity. In the contrast, on the pre-treatment, you can clearly see that it was bright on diffusion because it had restricted diffusion. How about this patient? This is a 58-year-old male, has colon cancer. The numbers don't matter, but you can see that it was enhancing. went from 135 to 195, was about 2.4 centimeters. The ADC was relatively low, it was 0.9. Following therapy, you can see that they are adequately and appropriately targeted the lesion. You can see now that the lesion didn't change that much. It went to 22 millimeters. It still showed enhancement, which was interesting. But notice that the ADC went up. It went from 0.9 to 2 because there's more free water. There's been a response to therapy. It's only by the 3-month period where you can see that it's no longer enhancing, it's necrotic. And now the size clearly has gone a lot smaller from 24 millimeters to 15 millimeters. And the ADC actually went down a little bit, but it's certainly higher than it was before. And it's bright on the ADC map, while before it was dark on the ADC map. How about this patient? Well, this one's a nice case. So we have 2 lesions, right? We have an arterially enhancing lesion here, another one here. We can see that it's washing out here and washing out here. It's bright on diffusion for both the lesions. But notice this lesion, if you just had the post contrast, it's hard to assess, right? You might be confused. You might say that this is still enhancing. You may be worried about the lesion, but notice now that we add diffusion to the mix, increases your confidence level. You can confidently say that it's no longer restricting diffusion, so there's been a good response. The other lesion is a lot easier. Now it's completely necrotic, but here too, the diffusion was helpful because again, you could see it went from restricting diffusion to no longer restricting diffusion. Sometimes it's difficult, as I mentioned, you can get these peripheral reactive edema after the therapy. Notice here, you can see all this enhancement and this reactive enhancement, but notice it was helpful. Again, the diffusion, not showing any restricted diffusion. Before it was restricting, and at the time of explant, the tumor was completely dead. How about this patient? Well, this illustrates why sometimes these cases are really hard to assess. Here you have the arterial phase, here you have the venous phase. You can see that there's areas where it's no longer enhancing, but notice you add diffusion in the mix, you can see that this subtle area of enhancement, it didn't necessarily wash out, but it's clearly restricting diffusion, making you confident that it's most likely residual or recurrent tumor, probably from a different blood supply. So it might require retreatment. But I also thought the diffusion was interesting because notice now we look at the diffusion, we can see there's a lesion that's bright on diffusion, dark on ADC. And when you can look at this MR, even though it's a good quality MR, it was very subtle to see. So I thought the diffusion, even in the non-treated lesions, can be very helpful. So these are some early papers. Again, this was from 2008. We looked at, and Hopkins group and other groups have looked at this as well, but we looked at 20 patients following radioembolization. What was interesting is that the targeted tumors didn't change significantly in size, but the mean ADC percentage change at 1 month increased 10.5%, preceding the overall tumor size percentage change at 3 months. So we only saw a change in tumor size at 3 months, but the diffusions did show an earlier change. This was a similar study from Hopkins group, in this case looking at cholangiocarcinomas, which can be really hard to assess. They looked at volumetric ADC values 3 to 5 weeks after therapy following chemoembolization, and they found that an early decrease in enhancement didn't correlate with survival. But looking at that volumetric increase in ADC values, you saw that it did correlate with survival, whether it was over 1.6 or it increased by 45%. And here's an illustration where you can see that the shift of the ADC values to the right and where they became higher values, that suggested that there was going to be a good response and overall survival improvement. We did some study after this because I wanted to look at it as well. And we could see, again, looking at the actual diffusion images, excuse me, it was hard to assess. You can see that it was adequately targeted. As I mentioned, you can see that area of enhancement. But what's interesting here, and this could be time consuming, so we don't routinely do it, but for this study, we did do it. And you can see there's a shift of a lot of the tumor, the volumetric shift to the right because the ADC values increase because of more free water. Let's look at some examples of a tumor assessment response. Here's the first example. This one's obviously pretty easy to interpret. This one's arterially enhancing after therapy at 1 month. It's completely necrotic. 8 months, it's completely necrotic. There's some volume loss associated. That's normal. There's some enhancement around it. That's normal. Don't confuse that with infiltrative tumor. So this would be characterized as an LRTR non-viable or mRECIST complete response if you use those criteria. Another example, this one's a non-viable. Again, if you look at the size, you wouldn't see that there's a significant change, but it does lack enhancement with the exception of the periphery, which I mentioned is normal and you shouldn't worry about that. Explanted, Again, nicely illustrating the tumor here, the relatively narrow zone of transition. This was more lobar therapy, so probably there would even be less involvement. And you can see if you're a pathologist that it went from live tumor to necrotic tumor. This was a patient with colon cancer to segment 2. We don't routinely use EVIS for these patients, but it nicely illustrates. You can see that there's activity on the PET scan. It was treated, and it nicely illustrates with the EVIS the area of the tumor as well as the zone of transition of the normal tissue that was affected. And this usually resolves or decreases in size. How about this patient? Well, this shows you how it can be hard to interpret. This is a patient with an HCC. You can see the arterial enhancement. You can see that irregular enhancement around it. You can even sometimes see, as illustrated here, linear enhancement or nodular enhancement within the lesion, but you got to be careful. And I tend to give them the benefit of the doubt, as I know that they generally respond, especially with the doses that they use, and they're so skilled at it by me. But this is 4 months, this is 1 year, this is 1.5 years. So don't confuse this little bit of enhancement with tumor. How about this patient? Well, this patient, pre-treatment, this is 1 month later. You do see that nodule enhancement. 3 months later, 6 months later, the nodule increased in size a little bit. So sometimes these nodules of enhancement are slow growing, but in this particular case, it probably had a different blood supply and could still be retreated if desired. This is, as I mentioned, often used as a bridge to liver transplant. If we were just using the necrosis as a criteria, you would say that there's been a partial response. If we use RECIST or WHO, you'd say there hasn't been a response. You might call this equivocal, but what's interesting, even at the time of explant, it was completely dead tumor. So it shows you that this nodular enhancement sometimes is not always tumor. Another example. Here's an example where you see an HCC. When I look at this, I look at the nodule, but what I like to do also is if they do it, I look at the cone beam images. In this particular case, they did a cone beam CT. You can see that the majority of the lesion is filling in, but notice that this nodule enhancement didn't show any uptake on the cone beam CT. There was no vascular flow, suggesting there's a different blood supply. So they actually went back in and found a different feeding vessel, which sometimes can be hard to find. But you could see that after following that therapy, there was complete necrosis. So even though there's a nodule enhancement, that is one of the things that I do like to look for, especially to see if it was completely treated or could there be a different blood supply. This was another study that we did. What we looked at patients, we looked at all the different criteria. We looked at them after transplant, explant, and with Y90 and sorafenib. What was interesting is no matter what criteria we use, whether we use RECIST, WHO, mRECIST, EASL, or ADC, none of them were exactly reliable. Complete pathologic necrosis, in fact, was seen in radioembolization at liver explant, and it couldn't be predicted by any of the different criteria. Necrosis was seen at explant, even though we thought in some of these cases they had residual tumor. And it certainly shows that we need better biomarkers for assessing therapy following radioembolization. So in conclusion, as I've shown you, I think tumor response assessment is challenging following radioembolization. As I mentioned, you need to assess not just the traditional tumor size, the RECIST or the WHO criteria, but you also have to use other criteria, including necrosis, and that's been adapted by the LR-TR, as well as mRECIST and EASL. And as I mentioned, you want to assess your therapy based on the type of treatment, because enhancing nodular tissue, although it's presumed to be tumor for chemoembolization and RF ablation, and may require additional therapy, but it may not be tumor, as I mentioned, for radioembolization. And following radioembolization, you certainly need, as I hopefully emphasized, longer follow-up imaging to see a response based on size, and you need to rely on other features. And a lot of times I do give them the benefit of the doubt because I do know how effective the therapy is. I'd certainly like to thank the pioneers in this technique, as Ziv had mentioned, Riyad Salem and Bob Lewandowski, and we've got a ton of people who are well-trained, and certainly thank the other people as listed on this slide as well. Thank you.
Frank, that was absolutely spectacular. And luckily we have this tape because I'm going to need to watch this several more times. You've emphasized a couple of most immediate take-home points, which is at proper dosing, then a little more cautious in patients is warranted in this early imaging, given the complexity and variations that we're seeing. And we're spending much more time delivering much higher doses to more limited targets as a result of these outcome studies as well as these imaging studies. Thank you. We've got some additional material from our two other faculty, and I think that Rachita, if you have control of the desktop and you're ready to go, please.
All right. I am not able to share my screen. Maybe now.
There. Yeah, we can see it.
Perfect. So
Just slideshow.
Pardon?
Just start the slideshow.
Yes.
We're seeing it in presentation mode, so.
Sorry about that. How about now?
Great.
Perfect. So pertaining to this talk, there are three indications where we can use contrast-enhanced ultrasound to delineate the response to the treatment, intra-procedural immediately to see if the treatment has been successful or not, or post-procedure for residual or recurrent tumor. And the response can be seen as early as 1 week, especially after TACE. And of course, we can look for tumor in vein with contrast-enhanced ultrasound. These contrast-enhanced ultrasound or ultrasound agents, these are microbubbles filled with gas, and they're purely intravascular agents. And they have a very short half-life of 30 minutes, and they're excreted via exhalation. So patients who have renal failure, we can safely give contrast ultrasound to evaluate liver lesion and its treatment response. And of course, the dose is given so low that we can do multiple injections to identify different lesions with contrast-enhanced ultrasound. So I want to show you an example. This is a CUS LR5 lesion where we gave contrast show intense arterial enhancement less than 30 seconds. And typically the hepatomas, they show delayed washout after 60 seconds. And this happens to be a hepatoma. When we compare with metastasis or cholangiocarcinoma, they show immediate washout in less than 60 seconds. So this particular treatment was treated with microwave ablation, and right now we see a ill-defined gas cloud owing to outgassing of water vapor due to deposition of high intensity energy. But if we let, after 20 minutes or so, this cloud of gas disappears, and we can give contrast and identify then and there during procedure whether there's any residual tumor or not. Sometimes the contrast agent, they get suspended within these gas bubbles, and we can destroy them by using what is called flash pulse available with contrast ultrasound software. The MR was done after 3 months, and we did not see any enhancing component within the cavity or along the margin. Lipidol is not a concern on contrast ultrasound, just like MRI. Even a small component of tumor tissue, if present, can be seen with contrast enhanced ultrasound. The lipidol cavity in itself, if it's completely treated well, it is seen as an area of decreased echogenicity. The corresponding MRI showed similar enhancing component within the margin of the tumor. When we evaluate lesions following TACE, a positive response would be no enhancement. So in this particular case, there was a small lesion which post-contrast ultrasound showed this intense enhancement. Of course, we learned that the treatment cavities are usually larger to kill the micrometastasis along the microscopic metastasis along the tumor margin. But at the same time, we see this perilesional enhancement, which sometimes it may be thicker at one side and very uniform on the other, which may create a confusion. And this happens due to extravasation of the CT or MR contrast agent into the interstitium, and which is not a concern on contrast enhanced ultrasound because it is a purely intravascular agent, so it doesn't escape into the interstitium. And when the contrast was done, there was no enhancement during any of the phase. following injection. Similar to MRI, when we evaluate after 3 months for recurrence of tumor, contrast ultrasound also can delineate similar appearance of nodular enhancement along the treatment margin. So it does add value in selected cases to evaluate recurrence as early as 1 month or even 1 week, especially for TACE using contrast enhanced ultrasound. Trans-Arterial Radioembolization is very challenging, even with ultrasound, just like MRI. The only advantage we have with contrast ultrasound is that so much of enhancement which happens around the treatment, we don't see that just because of the single reason that the contrast ultrasound agent, they are intravascular. So when we do ultrasound just regular, we may not see anything. After injecting contrast, we see similar finding as noted on the MRI, where we see a thick rim around the lesion, and this lesion decreased in size following the time interval between these two studies were 1 month. So the lesion further decreased in size. So very similar imaging features as MRI. This also showed washout. But how ultrasound, contrast ultrasound can add value is by tracking the time intensity curve, tracking the enhancement of this nodule over time, and see whether it is uptrending, stable, or it is improving to label this lesion as a treatment specific enhancement or evolving change. So there are advantages. The CUS is insensitive to perilesional perfusion changes. We do not see pseudo-lesions or shunts, which sometimes create confusion whether these lesions are new lesions or there is recurrence of tumor. So that is not a concern with CUS. Of course, we can do reperfusion, which is we can restart the arterial phase. Say we missed the arterial phase during contrast injection, we can burst the bubbles and redo the arterial phase to evaluate the arterial supply to the lesion itself. Of course, this imaging technique has drawbacks. Expertise and experience is absolutely required. We cannot survey the entire liver. So for specific lesions, we can certainly apply the contrast ultrasound, and especially for questionable indeterminate lesions on MRI, we can look at those with CUS. It adds up 30 minutes, but overall, I think it does add value if we can alternate CUS with MRI to evaluate early recurrence or residual tumor, which can be treated in a timely manner for patient care. Will definitely improve long-term survival by early identification of these findings. The overall survival, the overall sensitivity by this meta-analysis done by this group in Thomas Jefferson Hospital for CUS, and comparing it with radiofrequency ablation and TACE, they found it overall sensitivity of 85% and specificity for 94%. So overall, I think it does add value to imaging treatment response, local treatment response for hepatocellular cancer, as well as the other hepatic malignancies.
So Khot, that's fascinating. I know that this has been advanced more in the Eastern Hemisphere than it has in the US, as in some institutions as a more routine tool for assessing post-intraarterial therapy response. Dr. Miller, any chance that this is going to make it into the criteria that's being worked on? Is this even on the table? The pictures are very compelling.
Yeah, no, it's beautiful. And I know a lot of people who've also donated slides, and they're huge advocates, obviously. So I think it certainly, will play a role. And I think it does play a role, as mentioned. I mean, I know we certainly have a lot of interest at Northwestern. Helena Gabriel is leading our contrast enhanced ultrasound. We're using it more and more. I do wonder, you did show like a nodule of enhancement. I almost wonder, is ultrasound going to have the same challenges following radioembolization as, MR as well? I mean, if you do see nodular enhancement, I think it'll be interesting, but I think they probably shouldn't necessarily call it tumor either following radioembo. So I think it'll be interesting, to actually write about that kind of a, findings after radioembo as well. but the images are great. And I think even like if you have somebody who's talented, I think for doing ablations, I think obviously if you could see where the tumor is, it's probably a lot better. It's not my area of expertise, but I would imagine, over just general ultrasound, it'd be great to have contrast enhanced ultrasound to guide your therapy, I would think.
I certainly think I'm underutilizing it in my ablations. So I'm very grateful to that. And I'm sure many of our interventional listeners as well. We can circle back to this, but let's make sure that we get to Professor Pesch, who's brought some interesting and enhancing cases, dare I say. AJ.
All right, thank you, Dr. Miller, for that thought-provoking talk, and to Rachita for such an interesting insight into an emerging modality. What I thought I could do would be to show several challenging cases that we've encountered, highlighting some of the difficulties that you've discussed in your talk and demonstrating what we believe is a need for a more nuanced approach to the LI-RADS treatment response algorithm in dealing with difficult cases like these. Case 1 here shows an infiltrative LI-RADS 5 lesion in the right hepatic lobe. This was treated with Y90. 3 months later, we see what may be thought of as kind of a typical post-treatment look for Y90 without focal nodularity or washout to suggest viable disease. The only localizing abnormality was this area of abnormal residual diffusion restriction, and what was an otherwise non-viable lesion, and without guidance from the treatment response algorithm about how to interpret such secondary features, this lesion was read as equivocal. Next case shows a minimally enhancing heterogeneous LI-RADS M intrahepatic cholangio. This was also treated with Y90. Post-treatment images 2 months later show again a minimally enhancing mass with any interval change in size or reduction in enhancement difficult to determine or quantify due to the mass's irregular and infiltrative nature. This meant that there was a significant amount of diagnostic uncertainty in our report about the effectiveness of the treatment. Last case shows a segment 4 LI-RADS 5 lesion, also treated with Y90. This was imaged 1 month after treatment. The lesion was again noted to be arterially enhancing and washing out, which was read as evidence of viable disease. This prompted immediate and likely unnecessary retreatment with TACE. These cases show the difficulties in interpreting, justifying, and conveying our level of certainty in determining lesion viability. My view is that the current treatment algorithm somewhat inadequately addresses these unique characteristics of radioembolization, whether that's how they handle secondary imaging findings like abnormal diffusion, quantifying change and enhancement of hypoenhancing lesions, as well as the persistent arterial enhancement and washout sometimes present in these successfully treated lesions. This uncertainty essentially forces us to go off script from LI-RADS in our interpretations, and I think that really reduces the confidence that our interventional colleagues have in our reports and can likely decrease the quality of care that these patients receive. What I think we need is a more nuanced treatment response algorithm, which ideally would incorporate features like the ancillary features like the diagnostic algorithm does, as well as maybe an additional treatment category specifically for radioembolization, which may include a need for prolonged post-treatment observation. And with this need for longer post-treatment surveillance, I think we could definitely be incorporating contrast enhanced ultrasound in that, as an adjunct to the routine CT or MRI, which we've seen has its advantages in imaging these lesions. So I'm wondering, Dr. Miller, what your thoughts are about, and the thoughts of our audience about cases like these, how you would have handled them, and certainly the potential for future changes in the treatment response algorithm, which is what we primarily use when, relating with our interventional colleagues.
Yeah, I think you summarized it really well. And those are outstanding cases that nicely correlate with the ones I showed. Do you want to go back to the different ones? We can go through them a little bit more.
Yeah.
The first one you showed, I thought was outstanding because these infiltrative tumors, even without treatment, they're hard to assess. They're hard to find the tumor. Certainly, I thought that, the enhancement in this example you nicely illustrated, the diffusion was really helpful. Initially it was, as you show on the slide on the left, there's a lot of restricted diffusion. It's enhancing. And then you showed the next slide shows it's still enhancing, so it's hard to assess therapy because it may not wash out, but I think you nicely illustrated it. And I've always been a big advocate of diffusion even before diffusion was popular, but here you could see that, the only area that you're seeing with restricted diffusion is that small area. The other area, which clearly had restricted diffusion before, is not restricting, and it nicely illustrates, as you mentioned, even though it's not a huge part of LI-RADS, I think you have to look at the diffusion and you have to interpret them with, like you said, the ancillary features. And this one, as I tried to illustrate, diffusion, is your friend. In this particular case, you can see that area of restricted diffusion is, consistent with tumor as opposed to the other area, which was effectively treated. And the nice thing is, don't say that radioembolization is a failure, because you can go back in and treat that area, that restricts now.
So we might have been better off calling this viable tumor, based on your confidence in diffusion. I think we were somewhat
I think so. But you can clearly see that it's at the margin, that the tumor, and the other part clearly responded. So, my thinking, at least I may be wrong, obviously, but my thinking is that, the majority of the tumor clearly responded. And this one may have a different blood supply, and you can go back in and treat it, but, don't say that radioembo was a failure. You can, go back and potentially, that it's responded, or you can wait. But, I think the fact that you showed that the majority, of it treated, sometimes we still wait, because, it doesn't mean that it's going to metastasize, for example. You can always wait a couple months too. And even if you call it equivocal, sometimes in this case, I might have said that, there's an area of restricted diffusion. It's hard to tell, is it responding, or is it, residual or recurrent tumor? And it's up to the IR guys. They follow, obviously, the AFPs and other things as well, how the patient's doing, how keen they are to get further therapy. But, sometimes they'll retreat them with radioembolization and not rush out to do systemic therapy or, other forms of therapy.
We have a comment that I'll read directly that came in from one of the professors at UVA describing a case that she had today. Quote, will you go as far as to say that if the lesion's getting smaller but has increasing restricted diffusion, should we say that it's now viable?
Getting smaller but increasing restricted diffusion.
Yeah.
Does that mean the ADC went lower or the ADC went higher? Because in my experience, usually when it's getting smaller, it's usually responding.
It went down.
And I guess my other question is, can you tell if it's the area that was treated, or if there was like an adjacent area and it was a different blood supply? Because what you're describing, to me at least, sounds like usually if it gets smaller, in my opinion, the whole area, do you have like a CT scan that shows, I don't know if you guys do it, but sometimes they don't always do it by us, but sometimes they'll do, Dyna CT at the time of the procedure, or some form of CT, to see if the lesion was adequately or appropriately covered. And then the other thing is, if it's in the dome, then sometimes it's a different blood supply.
Yeah, so in this case, it was the area that was treated, but you point out that this is information that that will not be available, and certainly not routinely, to everyone everywhere who's interpreting this, which is intra-procedural images that provide some cross-sectional mapping where things were delivered. And it may, one of the take-homes may be the interventionalist, which is the importance of getting that, even though we may have pre-mapped it beforehand, for this very reason and follow-up imaging. Thank you.
Yeah, I learned about it when Reed Omri was with us, and he had an NIH grant. And as I sort of alluded to, we had this interventional MR machine, and I didn't realize, I just assume if you treat it and, if you see something that's viable, it just means that the treatment failed. When in actuality, I think a lot of these aren't that the treatment failed, but they have a different blood supply. And as imagers, we're not as aware of that as the interventional community may be. So, I guess without seeing the case, it's hard to know what you're describing. I think it's reassuring that it's getting smaller. To me, at least, it suggests that it's potentially responding. And if, if they felt like it was targeted well, and as I illustrated that, that there's radiation effects along the whole course of it, then I feel more comfortable. I haven't seen too many that you're describing where the tumor gets more, quote unquote, more restricted, I guess. But I guess if it is restricted, then me either. Yeah, no, I mean, I guess the way you describe it, you have to at least say that there may be some viable tumor and decide what to do, because yeah, the example you're describing just seems a little unusual, at least to me.
Any take-home messages to the interventionalists, perhaps to emphasize what I said or go further, who are performing these procedures, as to what we want to make sure is logged so that this interpretation may be easier in the 1 or 6 week follow-up after TARE?
I think, at least by us, I don't know if by you, but they're really good about telling which vessel was injected, where it was injected, so that, because sometimes you'll have several lesions and then exactly, where it was treated. And then the other part of your question was at the 6 week interval. I like to give them a lot of times the benefit of the doubt. I mean, a lot of places will do it 3 months so they don't have to address that issue, but at least by us, they argue they want an early assessment just to see if it's going in the right direction. And then the other thing to realize is sometimes these patients have what I like to think of, several lesions, some in the right lobe, some in the left lobe. They want to see if let's say they treat the right lobe first, they want to see if it's responding to this type of therapy, and then later they'll go back in and treat the left lobe. So that's why they'll sometimes do, an early imaging. Although I think as an imager, it'd be a lot easier to, specifically look at, 3 months as opposed to, early 4 weeks or 6 weeks, as you described.
We're coming up on the end of the hour, but we have a couple of last comments and questions, one of which is, for nodule enhancement that may be transiently present after treatment, are there ancillary features, such as diffusion restriction, that may help decide whether it represents post-treatment change versus viable tumor?
That's a good question. Unfortunately, diffusion doesn't always help. Obviously, if the diffusion goes, so it's more free water, then it helps. But like the example I showed, there isn't always ancillary features, and that's the interesting part. So, it looks like it's viable tumor basically, and then tincture of time, I guess it is, just by waiting, you see that it does resolve that nodule. But the main thing, at least in my opinion, is make sure that there's not a different blood supply. And a lot of the interventional, we work as a team. I mean, the interventional radiologists obviously look at the cases. We look at the cases as well. And, if I see something that bothers me, I'll call them, on the phone and say, well, what do you think? And, we'll discuss it together and come up with, a consensus, and an approach, should they retreat or should they just wait? And a lot of times they just end up waiting, and they're comfortable waiting a few weeks, and seeing if there's been a response.
I think we're getting much more comfortable with waiting as we're now focusing on delivering much higher doses to treated areas as well than we did 10 years ago. And I think it looks like our last question will be to Professor Khot, which is, are you aware of any comparative study for the use of contrast-enhanced ultrasound that looked at post-TACE and histology as in gold standard for accuracy?
Initially, you said a lot of studies done in East, they do have comparisons, but currently there are many studies being done across United States to look at the treatment response and compare it with TACE, TARE, radiothermal ablations, how these are, these two modalities compare to and what the explant actually shows. So not at UVA, but of course at different institute, it's being looked into.
I have one other point I want to make. The other thing is with these higher dose therapies, like I showed that example, where it didn't look like there was a response at 1 month and then it took a long time. I mean, I think a lot of these with these higher therapies, you're actually seeing necrosis early on. So I think they're a lot easier to interpret than it used to be. Obviously, I show you some of the more challenging ones, and AJ had shown some of the more challenging ones as well. And I think that's, the case, at least with MR, the examples we showed. And the ultrasound I thought were outstanding and very interesting, from, my perspective.
Well, I think we're at the top of the hour. So we're going to wrap this up. I am very grateful to the three of you for this extraordinary presentation. And I'm as grateful that we're going to have this taped and up on our faculty website, faculty development website, so that this can be looked at certainly by me and my colleagues again and again, and we'll make this rapidly available. Outstanding evening in an area of complexity and evolution. Thank you so much, everyone.
Thanks for having me. Appreciate it.